there is a formula for developing communication and language. So often, a lot of families come to us, of course.
All right. Hi, I'm Lisa Davis. Welcome to the second episode of the Autism Truth Podcast, brought to you by AutiParent. Joining us today is Dr. Charlene Marie Samuel to talk about things like why is my child not talking yet? And also looking at screen time and does that affect speech? How much should we be watching? Charlene is the director and owner of Autism Behavioral Center. She is a trained ABA therapist, I should say Dr. Charlene, and team leader working with children in the spectrum in Malaysia since 2009 under the tutelage of the Pioneer Center of ABA in Malaysia, as well as having the opportunity to work alongside consultants and BCBAs from USA. Dr. Charlene has worked with children and individuals of all ages within the spectrum and developmental delays in general. She possesses a professional doctorate, PhD, in business management from the European International University, Paris, a Bachelor of Psychology, Hans, from Help University College, and a certificate in special education needs and learning disabilities. She is also a certified play therapy practitioner, and she is awesome. Hello. Do you prefer Dr. Charlene,
Thank you,
Dr. Charlene
Lisa.
Marie, Dr. Samuel?
Just Charlene is good. Thank you so much for the
Oh,
introduction.
all right. Well, Charlene, this is what I'm curious about. What are some typical speech and language milestones for children from birth to age 3? And then I want to talk about what happens when we're not seeing that.
Yeah. Okay, that's a really good question, and I love talking about this topic. A lot of what I'm about to share, these are not limited to autism, which is a lot of the work that my career is centered around, but a lot to do with developmental milestones and very early signs, early developmental milestones we expect in language. So actually, language skills, see them as early as 4 to 6 weeks. We start seeing children responding to sounds first. So when very, very young, your newborn essentially, the first early developmental milestones, 4 to 6 weeks, you're expecting them to respond to loud sounds. They get startled when they hear loud
Yeah.
sounds. Around 4 months, you should expect to hear babbling. So, from a clinical standpoint, this is what we call vocalization or
Yeah.
vocal behavior. So, vocalization is a prerequisite to speech. So, if your child
Okay.
is not babbling, they're not vocalizing. This is a red flag for us as well. So, that must be present first. At about 6 months, and again, every child is different, so just give and take, plus 1 2 months, but essentially these are the expected milestones for these ages. At about 6 months, we expect them to start responding to their name. So, if you say hello Charlene, and then you expect children to smile and reciprocate with your smile. They
Right.
should make these cooing sounds, like, when they're happy, when they're
Yeah.
joyful, and you also hear like the disgruntled grunts when they're not comfortable, and you start to see this very early at about 6 months. And
Okay.
roughly at about 12 months, there is a lot of language that we expect already. We expect children to be able to, shake their head if they don't want something. Early words like mama, dada, papa, whatever that you call yourself. Um,
Mm-hmm.
and early sounds like, oh, oh
Yeah.
no, so children.
That's so cute, by the way.
Yes, but we see this, very early. We expect very early sounds and like almost like phrase completion, and we go oh, and the child may go oh, oh. By
Right.
18 months, so this is 1.5 years old, we're already expecting children to be able to request for what they want. So this is single words usage first. So typically, children would request for mama or dada or milk, um,
Right.
or cookie or nana for banana. Any common single word items
Yes.
can indicate very clearly if they don't want something. They should already understand simple instructions by 1.5 years old. So, for example, bye bye, kiss
Yeah.
or clean up, um, you know, um, good night, 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 whatever language, whatever terms that you use at home. A lot
Hmm.
of parents would you use certain terms to mean certain things, like night, night could be good night or time to go to bed. So children should associate certain parts of the day with these expressions of instructions.
Right.
By 2 years old, children should already be phrasing actually. So they should be very familiar with people around them. They can differentiate, who's daddy, who's mommy. If they have a sister,
Hmm.
if I'm in the
Yes.
room and and maybe I'm the sister, Charlene, where is Cece, for example, you can find them. Uh,
Right.
Already starting to build 2 to 4 word phrases or sentences,
Hmm.
understands action, verbs, like
Right.
eating, sleeping, jumping, and by 36 months, so about 3 years old, essentially. 3 years old is actually a very pivotal age. I
Mm.
personally feel in children's development, they are
Okay.
essentially little adults. At a 3-year old point, you can actually reason with your child. They understand most of what's happening around them. They're very
Mhm.
aware. Um,
Right.
they understand prepositions. You can have a simple conversation with them. Say, you're doing the groceries or you're cooking. Okay, mommy's cooking eggs today. Do you want one egg or two-way eggs? And your child should be able to respond at this point. So there's a lot of expectation of language and comprehension at
Okay.
26 months. And at 48 months, at 4 years old, essentially, I mean, from a child perspective, it's almost like you have a teenager already. So grammatically,
Yeah.
actually, a lot of their language
Right.
is understandable grammatically, getting closer to what we expect. They should be able to sing songs from memory, hum songs. They should know their name, how old they are, simple conversational
Okay.
questions. It shouldn't be a problem. So, actually,
Okay.
very early signs, Lisa, we can see it. Babbling starts as early as 4 to 6 months, and it develops from that point. Um, for us, when we are screening for developmental milestones, when parents come to us, we're always looking at the 18-month point. 18
Okay.
months, we are already expecting children to be verbal. They can ask for what they want. They understand simple one-step instructions. Actually, there's quite a bit of comprehension already present at a child
Hmm.
1.5 years old. So families or parents don't have to wait, till their child is 2 or 3, to get
Right.
their child screen, assessed, or to be concerned whether or not their child is talking, because this should happen already at a point of 18 months. So
Okay.
hopefully that gives a good representation of.
Oh, absolutely. Well, it's funny because I was about to ask at what point should a parent become concerned if their child isn't talking yet? And did you just say if they're not talking at 18 months? And also if all the other things you mentioned about the babbling and the cooing and the grunting and, showing, saying, oh no, things like that.
Yeah,
That's a concern.
absolutely.
Okay.
I think 18 months with certainty, if your child is not speaking, it is 100% a speech delay at that point. So the speech delay could be an outcome, it could be a symptom of just having a speech delay, or other
Right.
other concerns that we could have, including screen time and it impacting development of speech. But essentially, quite comfortably, if your child cannot differentiate between mommy and daddy at about 12 to 15 months, because they are main carers, their world evolves around you. It's safe to say that if there is no comprehension of who is mommy and who is daddy at 12 to 15 months, you already have to be concerned. And at 18 months,
Okay.
if your child is not speaking, then further concerns are then legitimate, because prior to speech comprehension, a certain level of understanding happens first before children start to speak.
Yes. And I was going to ask about how does receptive language, which is understanding, differ from expressive language, speaking? And why is that distinction important?
That's a great question. A lot of families always aim for their child being able to express themselves, so vocalize or speak. This is the expressive part of language. But as you've just shared, we also have the receptive part of language, which is
Right.
understanding. So often, especially when we are looking at stereotypical symptoms of children on the spectrum per se, what we often see is we see a delay in both receptive, which is understanding,
Um,
and expressive, often, not always, but commonly. So this raised a red flag for us, especially when a child is not speaking and they don't understand. But essentially, the
right.
distinction is children tend to understand more when they're young, even prior to developing the speech. So you would expect a child to understand simple routines. They will associate certain tasks, like for example, when it's time to have a shower or a bath, they would know that it's time to go to the bathroom, it's time to take the
Right.
towel, it's time to take their soap. Even though they may not say towel please or I want soap, but there's an association of certain routines. They know what comes together.
Right. That's the receptive part.
Yes, and a lot of receptive not only comes with receptive instructions, means it's not only about understanding instructions that parents give, but essentially
Right.
what the day looks like. They start to understand what comes together. So, for example, when it's time to brush your teeth, we would expect a child to go towards the bathroom or take the toothbrush versus
Mhm.
taking a
Yes.
plate or a cookie, for example, because
Right.
some level of associations and understanding has been made, even though a child is super young at 15 to 18 months. And then language comes later, so expressive. So 15 months onwards, this is where we expect children to start developing their vocalization and their words, which will then form their expressive communication. So they can express themselves, they can express their needs. And expressive language is not limited to speech. It can also be using PACS, picture exchange communication devices. It could be using SGD. It could be using sign language, but it's essentially
Right.
any form of expression of communication and needs would fall under expressive language.
All right. Now, how does your ABA clinic approach early communication challenges in young children, and especially if they're suspected to be on the autism spectrum? And actually, I'm going to ask you to tell us a little bit about ABA before you answer that, because people might be like, but I don't know what an ABA clinic is. Although I think a lot of people do, but just in case.
Okay, all right. So
Yes.
I'll explain ABA first. So ABA essentially is a
Yes.
science. There's a misconception that ABA is predominantly a therapy per se, but actually it's a science of teaching, and there are fundamental core principles in applied behavior analysis. That's what it stands for. So essentially, it's breaking tasks down. This is what we call task analysis, breaking them down into small chunks to teach, and we are constantly reinforcing the behavior or the response that we want to see. So again, ABA is a science of teaching. So how it can be applied in different clinics can differ, but essentially what the science tells us is behaviors are likely to occur again when we reinforce behaviors immediately. So, for
Okay.
example, if I were to say cookie and immediately I get a cookie in future, if I want a
Yeah.
cookie, I'm likely to say cookie again. So
Ah,
this is
I like that.
just an example of how reinforcement plays a role in the fundamentals of applied behavior analysis. So when we're using it in teaching, particularly with children with developmental delays, and it's widely used for children with autism, essentially we are targeting all of the appropriate behavior that we want to teach. And often with children on the spectrum or children that have autism, the three areas that we're tackling fundamentally in ABA therapy would be speech and communication, teaching social skills and reducing inappropriate behaviors, and teaching socially appropriate behaviors. So this is what we would tackle on. So that's a little bit about ABA, but essentially for a non-clinical eye, ABA, if you came to our clinic, it should look super fun, super engaging. A
Yeah.
lot of families.
I saw a great YouTube video, by the way,
Oh,
where
right.
someone
Yes,
came to the clinic. It did look like fun. It reminded me of my daughter went to OT.
yes.
We didn't do ABA, but she went to OT, and yeah, it
Okay.
was
And it essentially it should be fun because we are working with children.
right.
Essentially it's almost like their communication or their love language is play, it's interaction. And when we can find something that motivates a child, interests them, it's easier to teach. Um, so it
Definitely.
should be fun, it should be engaging. We use a lot of reinforcement to shape behavior essentially. Now, coming on to the next question, Lisa, sorry if you don't mind.
Oh, I was asking about what at the clinic, how do you work with kids who have a language delay?
Okay, great. So there is a formula for developing communication and language. So often, a lot of families come to us. Of course, the main goal is to develop speech and communication. Speech is always our main goal, and this is always our priority. But the reality is, a lot of the children, actually, a majority of the children come to ABC and they have yet to develop the prerequisite skills to develop speech. So, what are the
And ABC, just to interrupt so people don't get confused, that's the name of your clinic,
That's
right?
right,
So there's
Autism Behavioral
ABA and
Center.
then there's ABC. Okay, I just don't wait, I thought it was ABA.
Yes, you're right. So sorry, ABA
Oh,
is the science, applied behavior analysis. ABC,
mhm.
Autism Behavioral Center. That's the name of the
Right.
clinic. Thank you.
Oh,
Um,
sure.
so coming back to it, there is a a formula for developing communication. So the formula is number one, the child must have vocal behavior. The child must babble. So this is one of the milestones we spoke about that we expect around
Yeah.
6 months. And the most important skill is imitation. So if you think about it, everything we can do today as adults, maybe we speak another language, maybe we dance, we play the piano, we can drive, we can read and write. So how did we develop these skills? If you really think about it and you break it down, how we develop it as either a child or an adult would be we observe somebody doing it, they modeled it to
Right.
us, and then we
Mhm.
copied and we copied and we practiced to the point of
Yeah.
mastery. Now, what happens often with children with developmental disorders or delays, which is not limited to autism, is often they are not observing, particularly with children with autism and any developmental disorder that limits the child's attention and social awareness.
Mhm.
So, if the child
Right.
is not observing, they lose opportunities to firstly observe, as secondly a lot of the children that we see coming through the clinic, they either have no imitation skills, they do not know how to imitate. And when
Mhm.
I mean imitate, is mostly imitating on demand, imitating when you need to imitate, when you need to learn.
Right.
Or we have children that can imitate, but they imitate very inconsistently. So it's almost
Mhm.
like, oh, if my child is having a good day, if he's in a good mood, he will respond to you. So
Right.
it's not, you're not going to get much of a response. So in intervention, in ABC, what we work on is prior to developing the speech and communication. And communication can come in many ways, like through pictures,
Mhm.
PACS, sign language, which is all the options that we have in ABC as well, depending on the profile of the child that we serve. But essentially, we're
Mhm.
developing these three criterias: vocalization, imitation of actions first. So
Mhm.
imitating actions is easier to be taught and prompted. And finally,
Okay.
is imitation of speech. We call this echoics, or to echo. Say
Mhm.
say mama, mama, say
Right.
cat, cat. So that is the foundation of developing speech and any other skill. The foundation is imitation, but particularly for speech, the child must have vocal behavior first. So one of the
Okay.
things, Lisa, that we see as well, some children do have some vocalization, but we also see a very minimal repertoire of sounds. So what are the common sounds we hear? Early sounds would be ah, e, s. These are early sounds, but when we put these sounds together, it is not enough, for example, to say mama or cookie or milk. So having a huge repertoire of sounds that a child can make is also a prerequisite for speech. So we work on building a very strong foundation. Once a child can do this, developing speech or other forms of communication like sign language. So predominantly sign language, the prerequisite is the child must be able to imitate. Because,
Okay.
so, for example, if I'm teaching the child trampoline or ball, for example, how I would teach it would be through imitation. So do this ball, and then the child goes ball, and then we present the ball, for example.
I
So
see.
it's almost like a formula. Essentially, ABA is a science. It's been used for many years. It's trial and tested, and it works.
Right.
But again, the application can differ according to different clinics. But this is how we do it in ABC, and it works really well for us. And so far, yeah, we've got actually in terms of communication, Lisa, we have 100% track record. Every child that comes
Ah,
to us develops communication skills, not speech particularly, because speech there is a prerequisite for it, but every
sure.
single child does develop a form of communication in ABC.
Wow. Now, are there other professionals that are typically involved in assessing and supporting speech and language development? Like I think about a speech pathologist. Where do they come in? Or do they in what
Yes,
you
they
do?
do. So often we work with speech and language pathologists because, from a fundamental standpoint of developing the vocal behavior and sounds, and developing more words, we are skilled to do that. However, where behavioral interventionists, our shortcomings often lie is working on fluency, pronunciation, certain movements of the tongue and mouth that will produce certain sounds. So, particularly, ABC, Autism Behavioral Center, is our principal clinic. We also do have a sister brand, Speech Academy, which we do have speech and language pathologists as well as occupational therapists. So we essentially believe in multidisciplinary support to provide access to care for children with different needs. Now, not
Right.
everybody may need a speech and language pathologist, but particularly we work a lot with speech and language pathologists for children with fluency, pronunciation, production of certain sounds. Like often what we see is children that may drop the S sounds. So instead of
Right.
saying bus, they go ba,
Yeah,
or
great.
dropping certain sounds, not pronouncing them well. So we work a lot with speech and language pathologists for that. We can also work with speech and language pathologists for feeding. We are also trained to do feeding intervention. So does some occupational therapists and speech and language pathologists as well.
Oh, great. I'm thinking about kids who are, or children who are nonverbal,
Yep.
and you still work with them as well. And is that working more on the receptive or with the sign language or other ways for them to communicate with computers? Or if you can talk a little bit about that, because not every child is going to have speech, correct?
Absolutely. Actually, I would say 9 out of 10 children that come to ABC are nonverbal and they do not meet the prerequisites of speech yet. So
Okay,
through intervention, we get them ready. Sometimes
I
it can take
see.
a couple of weeks, a couple of months, and some children more time than that. But what about children that have not developed the prerequisites of speech? So we work very heavily on increasing vocal behavior because we always want to prioritize the opportunity to develop speech. That's really important, especially when a
Right.
child is young, because that's when you're going to get the most out of intervention. Now, what we focus mostly in intervention is actually imitation, because through imitation, as I mentioned, we can teach anything,
Yeah.
including learning to use sign language, teaching children how to discriminate, teaching children different labels to develop their receptive language. So, mostly for children that are non-verbal, we focus a lot on developing their comprehension and understanding, because you can be non-verbal, but it doesn't mean that you don't understand. So definitely
Exactly.
through intervention, we've seen a lot of children that may not be quite ready to speak, but they absolutely understand your instructions, they understand routines. Essentially, you can speak to them pretty typically and they can follow the day, but they may still have limitations with speech. But through intervention, we teach other alternatives of communication. So, not being able to speak doesn't mean a child can't learn to communicate.
Let's talk about screen time and speech. There's a lot of concern about screen time. And in your professional opinion, is it a friend? Is it a foe of speech development? Is it somewhere in the middle? Tell us your thoughts.
Okay, there is already research published on this topic, and from my professional experience, we've seen, pre-COVID and post-COVID. I think anything in healthy doses is okay, but what we know today is screen time before age 2, too much of screen time. It's not beneficial for the child. And we're also seeing a lot of this, Lisa, as well in intervention. We are seeing mostly uh, typically developing children, so they are not showing signs and symptoms of autism. So, no repetitive behavior, they don't really have much sensory challenges. They can follow instructions to a certain degree, but very clear delays in speech. And often, what we see is parents now, both parents tend to be working, or they leave them with
Yep.
with a carer or a grandparent, and the child is just in front of the TV all day. So what we
Yep.
know today, research and our experience both tells us that too much of access to screen time is definitely not a good thing, because children and humans, essentially, we are social beings. So a lot of the early developmental milestones children learn through social environment. So definitely keeping children in isolation and expecting them to learn from a screen is actually not how we are wired. We are wired to learn through social responding and social exchanges. We are seeing, actually, we have a lot of children coming in between the age of anything from 14 months. Our youngest enrollment is about
Oh,
14
wow.
months, right
Hmm.
up to about 2.5 years old. And a lot of the children we are seeing are not necessarily on the spectrum, but very clear developmental milestones are missed in the language area. So for now, I would say anything below the age of 2, unless you're the research tells us, unless you're doing a video call with mommy or daddy, that's maybe not in front of you, that's acceptable. But
Right.
it is recommended right now for children and younger than 2 years old, it would be zero minutes of screen time. And that time should be instead used to play and engage with your child. So what's happening right now, Lisa, is I think screen time on its own is not a bad thing, but the problem is screen time has replaced socialization and social interaction.
Yes.
Yes,
Especially nowadays.
exactly.
It's horrible.
We see children. How often do you go to a restaurant and you see
Oh my gosh.
it's
It
becoming,
drives me crazy.
and so
And
does it to me. But
it's like, can you interact with your child? Sorry to interrupt,
yeah,
but it's one of those topics that I just, I just feel bad for kids today
it's a very different
because it's
way
a
of growing up.
screen, constantly looking at something that's not helping them with their interpersonal skills or their communication skills or their brain development. And it's just too much. So how do you, it's just such a complicated situation. What do you say to parents who are like, yeah, but I have to work 2 jobs and I'm so busy. Like, I don't want to seem like a snob, but I also feel like, yeah, I get that. And Charlene, what can they do, to cut down on the screen time? Because they use it as a babysitter, a lot of people, even people who have one job, or even moms or dads or caregivers who have lots of time on their hands, they
Yeah,
still put a screen in front of them because
you're
it's
right.
it's right there on your phone. And again, not judging.
Yeah,
I'm
yeah.
just passionate about this.
Yeah, so am I. And I think actually the bigger problem here is it's become socially acceptable,
Right.
and it's become a norm. And I think that is more of the problem. Devices have become so accessible, so affordable, and even as adults, a lot of us are addicted to the screens. If we look at behavior of parents slash adults, how many of us, the first thing we see in the morning is your screen, not your
Yep.
partner, and the last
I
thing that we
know.
see in the end of the day is your screen and not your partner. And you can see that
Right.
we are growing up, and we are living in a very different environment. And unsurprisingly, of course, the way we are living is very different to what it was 10, 20, 30 years ago. But I think everything it's not a foe per se. It's not bad, but I think there has to be a level of balancing. So if that means, you have access to some screen time, but you should be pairing that with equal opportunities of social interaction with your children. What we're also seeing, also Lisa, a lot of young parents, um, they don't know how to play with their kids. Yeah,
Right.
because again, all of the time has been replaced. So I would say any extreme is not great, because you're right. Sometimes we
Right.
do need to switch off, and it may not be um, as easy as being switched on all the time for your child after a long days of work. But I would say any amount of screen time. So if you're giving your child at the end of the day 30 minutes to access the screen, I would pair that with 30 minutes to play with your child. If it's 15
Yes.
minutes on the screen, that means you get on the ground and play 15 minutes, and it's play. It's not teaching them, or doing homework. That is not
Um,
play, because young
Reading to
children,
them too, right?
reading, yeah, and making it fun, and
Yeah.
also because this is probably more from a cultural perspective. Often, Asians are very academically inclined, so we're doing reading as also a form of learning to develop literacy very early. But
Right.
actually, it's making reading fun and engaging, and teaching
Yes.
children emotions, and all of that through reading a book. So really, essentially, anything you do, even it could
Yeah.
be, making dinner, you could make them playtime too. You can get your child
Yeah.
to join in with you, take turns, narrate everything you're doing. So it's not necessarily getting on the ground and playing blocks with your child. But
Right.
what we know is humans are social beings. We learn and we thrive through social engagement. And a lot of this is being replaced. And that's why, particularly, screens on its own is not the enemy, but essentially screens is replacing quality time.
Right.
And that is the problem more than
Yes.
anything
Now,
else.
speaking of parents and parental involvement, they go to the clinic and you do amazing work. Do they have homework? I hate the word homework, but do they have things to do with their child at home to reinforce the things that you're teaching them?
Absolutely. And I think this is one of the ways that we might be different from many clinics. So, what is a
Mm.
norm here in Malaysia is a lot of families send their children to intervention. Essentially, the interventionists do the work, they send the child home, but there's very little communication between the interventionist, the clinical team, and the parents, and there's no homework.
Mhm.
So, for us, we do two things. We keep parents involved by monthly parent meetings, so they are very involved with
Oh, good.
the prioritization of our programs, what are we teaching, the targets that we're selecting, and more importantly, we do parent training. Because in the end of the
Oh,
day, a very big part of the work we do is we want to educate and empower families. Intervention is part of your life, but it's not your whole life. So we are there
right.
to set up a good foundation, equip families and schools with the skills they need, and the goal is for us to fade off. If there is a full reliance on interventionists and ABC, actually, not that's not a great thing. Of course, from a business perspective, that's great, but for the quality of the work that we're doing, that's not great, because
Right.
that leaves families without the skills to support their own
Mhm.
child. So I would
Yes.
say, for families that are doing shopping of who would support you best, pick a clinician, interventionist, or a clinic that will provide you the tools you need to continue the work at home. Because in the end of the day, if your child is responsive in the clinic, if your child is compliant, no behaviors, he can request, he can have conversations, and he comes home and he can't do any of that, that's not a
Yeah,
good quality of life. So generalization of skills
exactly.
is really important. And often, particularly, we see in autism is we see a level of rigidity. So in ABC clinic, I can do all of these things, but at home, I don't do these things because this is not what is expected. So
Right.
these are the rigidities that we want to break very early on, and we essentially we empower families with the skills. A lot of our families that have journeyed with us, so they've been with us for 1 or 2 years, they are as skilled as us. They are
Oh, that's
good.
amazing.
They themselves, I would say, are really great clinicians and interventionists, and they advocate for their own children. They know how to manage their child. They know how to get cooperation, and and essentially their life, the quality of life is improved. They can go anywhere. You can go to the
Fantastic.
supermarket or mall, but that's what we want. That the community and the quality of life must be beyond the clinic. Yeah, it needs to extend to your community and to your life. So yeah, to answer your question, we are very involved. We involve families in our meetings, target selections, and as well as training the parents. Not limited to parents,
Right.
some families are unable to make it, so we teach nannies, carers, grandparents, essentially any caretaker that works directly with the child. We
Hmm.
train them.
That's fantastic. Charlene, was there anything that you wanted to add that we didn't touch on today? And it's been such a great, informative conversation. You're
Oh,
delightful.
thank you, Lisa. I mean, as I'm as passionate as you are, I think I could keep going. But what I would say is learn the early signs. I think it's great that some of the pivotal milestones for very early on. We've spoken a little bit about that. If you're uncertain, wherever you are in the world, reach out to a clinic, and I'm sure many clinics would be happy to speak to you on the phone just to let you know whether or not you need to be concerned before even making an appointment. That is a commitment that ABC does. Actually, you do not need to walk through the door for us to give you support. Often
Oh, that's
a
nice.
lot of the work, Lisa, that we do is we are on the phone a lot of the time, speaking and working with families just to kind of indicate to them, do we need to meet, is there a cause of concern, and if there isn't, we will let you
Right.
know. And I think, I believe there are many clinics and interventionists that would be having the same ethical conduct as us, because it's yes, again, we would love to be part of your journey, but
Hmm.
also being a resource center.
Right.
Almost families come to us with the questions, we try to educate and direct families. Not everyone we can support, and the reality of ABA, particularly applied behavior analysis, it is intensive, it is expensive. In Malaysia, there is no government funding for this, so it's very different to
Okay.
America, where there is not particularly government funding, but there is coverage with insurance. In Malaysia, there isn't. So different parts
Oh,
of the world,
wow.
there
Okay.
are different, I guess, policies, because ABA is not, we're not quite as recognized as it is in the States. But that being said, because it's so expensive here, there are so many families who need the care that cannot access care. So
Mm,
ABC has remained as almost a resource center. We're happy to
right.
refer families along if they cannot afford our services. And again, we're happy to speak to families that if you have questions, concerns, we're happy to take that time to speak to you. It's not
Mm.
about making an appointment and paying a fee to get access to a reference or a referral.
That's a fantastic. Well, tell us all the ways we can find you and your great clinic.
Okay, great. So we serve families in Malaysia, and any families that are willing to come to Malaysia for intervention. Actually, half of the families we serve are expats or families coming from different parts of the world to access quality care. So
Mm.
you can find us on our website, www.abcautism.com.my. We're also on Instagram, abc.malaysia. So I'll send you all the links. But for more information, the website is the best way to find us. We have 3 clinics in Malaysia, and the goal is for us to be present in every state. So that is something that we're working towards.
That is fantastic. Dr. Charlene, I want to thank you so much for joining us. And I want to ask the audience, have you had a chance to explore AutiParent yet? If not, definitely check it out. It's a platform designed to support autism parents in Malaysia and worldwide. And I'd love to hear your thoughts on it. You can always message me at lisadavismph@gmail.com. I want to thank everybody. Keep coming back to the Autism Truth Podcast. Thanks so much.
Thank you, Lisa, for your time. Take care.
Thank you.